This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, everyone. Thank you again for joining us for this week's Neurology podcast. This is Andy Southerland from the University of Virginia, and I have the great pleasure of talking again with my friend and colleague, Seemant Chaturvedi, who is Director of the Stroke Division at the University of Maryland. And for this week's Neurology podcast, we're going to be discussing some really exciting new trials that have come out in the world of stroke that were presented recently at the World Stroke Congress in Toronto, Canada, that Seemant and I both had the pleasure of attending, and several of which have not been published yet. So we're going to talk about several of the trials, but first I'll just say, Seemant, thanks again for joining us and providing your knowledge and expertise on these new trials.
Pleasure to join you, Andy.
So as you and I both saw, there were a number of trials presented at the plenary session of the World Stroke Congress in Toronto, and they really covered a number of areas in the world of stroke. But the first category we're going to talk about are two new trials coming out in treatment of acute ischemic stroke. The first trial, called the ATTEST-2 trial, was a prospective randomized controlled trial of tenecteplase versus alteplase in acute ischemic stroke. And as many people know out there, there's been a lot of new research over the previous years on both the safety and efficacy of tenecteplase as a preferred thrombolytic in treatment of acute ischemic stroke. Many hospitals, including our own, have converted to tenecteplase as the primary thrombolytic, but still needed research in its efficacy and use compared to alteplase. So Seemant, what was your interpretation from what we learned from this new ATTEST-2 clinical trial?
Yeah, so thus far we've had two large-scale studies looking at tenecteplase versus alteplase. One was the ACT study in North America, primarily in Canada, and then the TRACE-2 study in China. And both of these studies did show that tenecteplase had comparable outcomes to alteplase in terms of clinical outcome judged by the modified Rankin's scale, and also similar rates of cerebral hemorrhage. So I think those gave a lot of reassurance, and as you said, your center has switched over, our University of Maryland medical system, we switched over last year, and many other places across the globe have switched to using tenecteplase because of the ease of its use as a one-time bolus instead of a 1-hour infusion. And so the ATTEST trial was, I think, providing further information along these lines. And the principal investigator, Dr. Muir, wanted to emphasize that the database hasn't been totally locked. And so the material he presented at the Stroke Congress was virtually complete, but it is not the total final data set, and there are still some outstanding queries. But this is similar in results to the previous two trials, that with tenecteplase, about 42% of the patients had an excellent outcome judged by MRS of 0 to 1, compared to 40% with alteplase. And the hemorrhage rates were similar in the two arms. And so I think this was sort of further reassurance that if your center has already made the switch, you should feel comfortable that you've made the switch, and it's a perfectly reasonable medication to administer to patients with acute ischemic stroke. If you're thinking of making the switch, well, you now have 3 large trials showing that it is comparable in efficacy to alteplase. And so I think for those audiences, it was reassuring and positive news about the use of tenecteplase.
And I agree, this is additional evidence in support of tenecteplase as a preferred thrombolytic agent for folks that are still using alteplase. I think that at this point, obviously, it's still a worthwhile, efficacious thrombolytic as always been, but there are some advantages to tenecteplase, including the one-time bolus, and perhaps for some centers, it can also be a cheaper option compared to alteplase as well. But great evidence, again, supporting this potential transition in thrombolytic use. I think will be of great interest to those out there. And we'll look for the full publication so we can vet that as when it comes out. The other trial that was presented at the World Stroke Congress in the realm of acute ischemic stroke was focused on patients with large vessel occlusions. And I think many of the folks in the audience will recognize that there's been some equipoise ever since the previous generation of endovascular therapy trials as to whether patients who have larger infarcts at the time that they present would additionally benefit for thrombectomy compared to not getting thrombectomy, as these patients were excluded from many of the previous clinical trials for concern that the infarct was already too large or that there'd be too high risk of hemorrhage from endovascular therapy. So this next trial we're going to discuss was called the TENSION trial, and it was an open-label randomized trial of endovascular thrombectomy for patients with established large infarcts. And Seemant, for our audience, tell us, what did you take away from the TENSION trial?
Yes, so as you mentioned, the sort of first generation of thrombectomy trials were designed to look at the ideal population, which is the patients who had a small core infarct with a significant area or a larger area of hypoperfusion. And those were considered the ideal candidates for a thrombectomy. In the last 12 months, we've had some additional trials in patients who have a larger amounts of baseline ischemic injury. And so the tension trial was one of them. But the unique feature of the tension trial is that it did not require advanced imaging. And so it relied on just the plain non-contrast CT or a stat MRI for the imaging criteria. And so it wasn't required to have perfusion imaging or other more sophisticated forms of imaging to delineate the infarct size. And so for the non-contrast CT, it primarily used an aspect score of a 3 to 5 as the qualifying condition. And so the investigators were able to randomize 253 patients, and these were very severe strokes with a median NIH stroke scale of 19. And the bottom line is that the patients who received thrombectomy did fare better in terms of the overall outcome on the modified Rankin scale. And if you look at the percentage of patients who achieved modified Rankin 0 to 3, it was 31% in the thrombectomy patients compared to 13% in the usual care patients. And so that was a definite increase. The somewhat concerning thing is that the mortality was fairly high in both groups. It was 40% in the thrombectomy group and 51% in the medical treatment group. And also, if you look at the overall rate of death and dependency, it was 69% in the thrombectomy group. And so I think that's noteworthy that 7 out of 10 patients, even despite the thrombectomy, will still have either death or significant disability. And so therefore, I think shared decision-making is going to be very important with the families of patients in this circumstance. And I think we need to sort of take each case on an individual basis. Patients who are elderly or who have a lot of comorbidities, one might expect they may not do as well. But I think we need to consider that these patients can benefit even without advanced imaging, but we need to individualize the treatment. I was curious, Andy, how has this trial impacted practice at your center?
Thank you for summarizing that. It's in flux, I would say. And there are going to be people who feel strongly on one side of this discussion versus another, probably on a case-by-case basis, depending on the additional comorbidities of the patient and perceived likelihood of a positive outcome. But the way I interpret this data and the way that begun to practice is that on the whole, that even in patients who seem to have suggestion of early infarction, significant amount of infarction, even on a non-con head CT, that they're more likely to benefit from thrombectomy if they have a large vessel occlusion versus not. And so I think if anything, it's like you said, Seemant, if you feel like this is someone that you want to treat and to give them the opportunity to have a good outcome, then I think it's further support to treat that population as opposed to sort of taking a nihilistic approach with people with large infarcts. At the same time, I'm not sure that we need to feel as a field compelled to treat all of these patients depending on their additional characteristic. So I'd say still somewhat individualized, but more emphasis to treat people that have larger infarcts. And the other thing I'd add, I think like many of our colleagues out there, we accept patients from more rural facilities for transfer for thrombectomy. And I think this is an exciting trial because it suggests that just with the non-con CT alone at one of our referring hospitals, we don't need advanced imaging to try to help make important triage decisions about whether to transfer them for thrombectomy, that this gives added information to help us make those decisions.
Yeah, that's an excellent point, that if you're a small to medium-sized community hospital which doesn't have perfusion imaging, you can still evaluate the patients sufficiently with the non-contrast imaging and then communicate with your comprehensive stroke center.
We should point out that of the trials we're discussing today, this one has been published in the October 11th issue of the journal The Lancet, so folks can certainly seek the full article out and judge for themselves about the results of the tension trial. So now let's move on and let's talk about perhaps a lesser known trial for a lot of our stroke community, particularly in the US. I think people are aware of the CHANCE clinical trial and perhaps CHANCE 2. These are clinical trials looking at treatment of early stroke prevention in patients with minor stroke and high-risk transient ischemic attack. And so we heard the results of the CHANCE 3 trial at the World Stroke Congress, which was a randomized placebo-controlled trial of colchicine in this population. So Seemant, tell us about this curious trial of colchicine in patients with minor or moderate stroke and high-risk TIA.
Yeah, I think our listeners will find this very interesting because for decades, we neurologists have just been hearing about various combinations of antithrombotic therapy, be it aspirin plus clopidogrel or aspirin plus ticagrelor or other forms of antithrombotic treatment. But this is sort of in a different category, looking at a potential anti-inflammatory compound. And colchicine is an old medication which inhibits microtubule assembly, and it can have some downstream effects on reducing interleukin-6 and C-reactive protein. And so this was a trial where they enrolled patients with high-risk TIA or minor stroke, and patients had to have an elevated C-reactive protein as well. And then they were randomized to colchicine versus placebo for 90 days. And overall, there was no difference in the two groups. The 90-day recurrent stroke rate was 6.3% with colchicine, 6.5% with placebo. So I think this was interesting, showing that within a short-term time frame after the initial event, there was no difference between the two agents. But I think this is definitely not the last we've heard of colchicine, because some at the conference commented that we may need a longer time horizon to show some benefit of the anti-inflammatory treatment. And so there's another trial in progress called CONVINCE, which is going to follow patients for about 36 months. And that could have some results in 2024. So I think that will be a sort of a useful companion to show, is there any longer term benefit of colchicine? And will neurologists potentially be adding that to our toolbox in the future? But at least for this short-term 90-day outcome, colchicine was not shown to be beneficial.
That's quite interesting. I'm excited to see this in full published form and dig into the data a little further. This would certainly be an exciting area for us if we had sort of an anti-inflammatory target in this category of high-risk TIA or minor ischemic stroke. But I suppose we'll look forward to this next trial before we remain convinced of the value of colchicine in that situation. And finally, last but not least, we don't want to leave out an important trial called ANEXA-1, perhaps ANEXA-I. I'm actually not quite sure of that, the last component of the acronym of the trial, but this was a trial specifically looking at the use of andexanet alpha in patients presenting with intracerebral hemorrhage in association with taking a factor Xa inhibitor anticoagulant. So this clearly is a very practical, everyday problem that we encounter. Patients who are on these direct-acting oral anticoagulants, particularly the factor Xa inhibitors, what is the true value of in this particular case, andexanet alpha and other reversal agents in managing patients with intracerebral hemorrhage? So Seemant, let's finish off and talk about this trial.
As our listeners know, with the aging of the population and the expanding group of patients with AFib, we're seeing a sharp increase in the number of patients who are on 10A inhibitors, such as apixaban, rivaroxaban, edoxaban. And so a small percentage of those patients will have intracerebral hemorrhage, and that can be potentially very serious. And so this trial looked at andexanet alpha, which is specifically sort of a designer compound to inhibit the 10A inhibitor medications compared to usual care, which frequently consisted of prothrombin concentrate. So here, the hemostatic efficacy was better with andexanet alpha compared to usual care. Hemostatic efficacy was achieved in 64% of the andexanet alpha patients compared to 52% with usual care. And if you look at growth of the intracerebral hemorrhage by greater than 12.5 ml, that was seen in 12% of the andexanet alpha patients compared to 19% with usual care. So that was also a signal in favor of andexanet alpha. On the other hand, the overall risk of thromboembolic events was higher with andexanet alpha. It was 10% with andexanet alpha compared to 5.6% with usual care. And ischemic stroke was increased by 5% with the andexanet alpha treatment. And then finally, if you look at the 30-day outcomes with the modified Rankin score of 0 to 3, there was no difference between andexanet alpha and usual care. It was 28% versus 31% in the two groups. So to summarize, the overall hemostatic efficacy was better with andexanet alpha. No definite difference, however, with 30-day outcomes.
That last piece is curious. I wonder if you saw a patient come in with that scenario and ICH in the setting of factor Xa inhibitor, would you go to the Pyxis for the andexanet alpha, do you think?
Yeah, I think this is another case where individualized treatment is going to be recommended because it's a fairly expensive medication. And so I think you would want to maybe reserve it for the patients who are at highest risk for hematoma expansion or highest risk for a worse outcome. And so I think this is another case where we also need to see the full publication and let the community absorb the results, especially our neurocritical care colleagues and our neurosurgical colleagues. And then after that, we could make a case-by-case decision based on this new data.
Fair enough. Well, I think that's enough of a round robin through these clinical trials and really great new information and answering some important questions in the world of stroke. So Seemant, thanks again for joining us, and encourage all those listening to seek out these new data in full published form when they're available. So thank you, sir.
Thank you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.